Welcome to Fireside Chat with Beth and Matt, where we simplify complex radiology topics.
You got it.
In today's episode, we explore the Fleischner Society's updated glossary.
Yeah.
And why mastering these terms is crucial for every radiologist.
Right.
Okay, so, as a radiologist, you're constantly interpreting, and communicating findings, right?
Yeah.
The Fleischner Society has essentially been the authority on the language we use in thoracic imaging.
Mm-hmm.
And this is actually their fourth glossary.
Wow.
Building on, previous versions from 1984, 1996, and 2008.
Okay.
It's a continuous effort to make sure that, our shared vocabulary is as precise as possible.
Right, exactly. And it might be kind of like, why another update? What has changed,
Yeah.
But think about how quickly our field advances. New imaging techniques emerge. Our understanding of lung diseases evolves, And inevitably, new terms enter our, daily discussions. And at the same time, some older terms might become outdated or their usage might just drift, leading to confusion.
Yeah.
So this updated glossary really tackles those issues head on.
Right.
So we're all on the same page, speaking the same language.
Yeah, that's so important for, you and your practice, right? It's about making sure that when you describe a finding, the clinician who's receiving that report understands exactly what you mean. And vice versa, right? They've really focused on those clinically relevant terms.
Yeah. That
have, shall we say, a bit of wiggle room in their interpretation.
Right.
So the core mission here is standardization. So whether you're consulting with, a colleague down the hall or even across the globe, the terminology has a shared, agreed-upon meaning.
I mean, yeah, especially with the increasing use of structured reporting and the vast amounts of data we're now dealing with in imaging databases.
Yeah.
I mean, this standardization is absolutely essential. Cool. If our terminology isn't consistent, how can we effectively search, analyze, and ultimately draw meaningful conclusions from all that information? Yeah. It makes total sense.
It makes total sense. It's like trying to organize a library.
Yeah.
Where everyone has their own unique way of categorizing books.
Totally.
And it's not just about solidifying definitions for, the terms we all agree on. The Fleischner Society has also kind of taken on those terms that are often misused or are a source of debate.
Okay.
And they provide clear recommendations for their appropriate use. It's like having a seasoned guide to navigate some of the trickier aspects of our professional lexicon.
Yeah.
And what I thought was really interesting is when definitive evidence was lacking, they explicitly state that, their recommendations reflect the expert consensus of the writing group.
Right, which really underscores, I think, the collaborative and evidence-informed nature of this glossary.
Yeah.
I mean, even when the evidence is indirect. Yeah.
They've also kept the scope very focused. Deliberately excluding terms and techniques that aren't specifically relevant to thoracic imaging.
Right.
So while PTCT might get mentioned in relation to some findings,
right,
the primary focus remains on, chest radiography and CT.
Yeah.
Which are, as you pointed out, still the foundational modalities.
Exactly.
In our field.
Yeah.
So
now, you might assume a major update would bring a huge surge of new terms.
Yeah.
But surprisingly, the total number of terms has remained quite stable.
Okay.
But what they have done, and which I think is really useful, are the new features that they've incorporated.
Yeah, the thematic grouping of related terms is a particularly insightful addition.
Yeah.
It allows you to look at concepts that are kind of closely linked side by side, which can really enhance your understanding of the nuances between them.
Yeah.
They've wisely maintained the alphabetical order.
So you can still quickly find a specific term when you need that refresher.
Absolutely.
Yeah.
And in your, daily practice, they've also streamlined things by reducing the reliance on imaging signs and eponyms.
Oh.
So it seems like there's a clear move towards more descriptive language, which ultimately promotes clearer understanding and reduces the need to memorize, a long list of names.
Makes sense. And while the references haven't been completely overhauled, for every term,
right,
the majority have been updated, which is a valuable resource if you want to delve deeper into that supporting literature.
Right.
But perhaps the most significant changes, at least for your interpretation and reporting, are how they've reclassified the terms.
Absolutely. This is where things get really interesting for your daily workflow.
Yeah.
They've moved away from those separate definitions based on pathology, radiographic appearance, and CT findings.
Yeah.
Now, each term is clearly designated as relating to anatomy, physiology, or pathology.
And it's crucial to understand their specific use of pathology in this context.
Yeah.
You know, they clearly state that while these labels are often informed by the correlation between imaging and pathology, you know, a term that is labeled as pathology represents a radiologic diagnosis.
Right.
What we see and interpret on the images,
Yes.
and not necessarily the definitive histopathologic diagnosis.
That's a really, really key distinction. It keeps the emphasis on our role as radiologists, you know, in describing and interpreting what we see on the images.
Absolutely.
The third major enhancement that I think will be, immediately beneficial to you is the inclusion of images.
Right.
Now, almost every term in the glossary is accompanied by a representative image.
Okay.
It's huge for visual learners, you know.
Yeah.
Like, many of us in radiology.
It really bridges that gap between just reading a definition and actually being able to visually recognize the entity on the scan.
Yeah.
Of course, as the Fleischner Society points out,
Yeah.
these images are typical examples, and they're not meant to be like exhaustive illustrations of every possible presentation.
Yeah, good guy.
But it's a significant step towards making this glossary more practical and educational.
Yeah.
You know?
Yeah. So overall, this sounds like, a very well-considered and timely update.
Yeah.
The Fleischner Society clearly hopes this will be an indispensable tool for radiologists and for the broader respiratory medicine community.
Right.
And they rightly acknowledge that, in a field that's constantly evolving, these definitions are consensus proposals, a foundation that we can continue to build upon.
Exactly.
Okay, so now that we have a good understanding of why this glossary is so important and what the key updates are, let's get down to the specifics and summarize some of these essential definitions.
All right. Let's start with a really fundamental unit, the acinus. So as the glossary defines it, this is the structural unit of the lung that's located distal to the terminal bronchiole.
Yeah.
Think of it as like the primary site where gas exchange occurs.
Right.
It's supplied by a first-order respiratory bronchiole, which is quite small.
Okay.
Typically measuring between 4 and 8 millimeters in diameter.
And for, kind of your understanding of lung structure, it's important to remember that a secondary pulmonary lobule, which we'll define a little bit later, is comprised of multiple acini, anywhere from 3 to 25 of them.
Okay.
And what's interesting is, in a healthy lung, you wouldn't normally be able to see individual acini on, standard imaging.
Right.
It's only when there's a pathological process, like, the accumulation of fluid or cells within them, that they might become visible.
Okay.
As those small, ill-defined, rounded opacities that we sometimes call airspace nodules. Okay, moving on to a more descriptive term that you'll encounter frequently in your reports.
Yeah.
Air bronchogram.
Yeah.
This is classified under pathology, and it refers to the appearance of air-filled bronchi that are visible against a background of airless lung parenchyma. So for you to see this, it implies that the, larger, more proximal airways are still patent.
Right.
And that the air in the alveoli has been either absorbed as an atelectasis or replaced by something else, such as fluid or tumor.
Right. It's like the normally invisible airways are outlined because the surrounding lung tissue has become denser.
Exactly.
Yeah.
Okay, and then there's the air crescent, another term categorized under pathology.
Okay.
This describes a very specific imaging finding, a crescent-shaped collection of air that forms between the wall of a lung cavity and some sort of mass that's contained within that cavity.
Okay.
And what's particularly notable is that, the sign is often associated with specific conditions. So, for instance, in cases of angioinvasive aspergillosis, it can be caused by the retraction of infarcted lung tissue. Or you might see it with a mobile fungus ball within a pre-existing cavity.
Okay.
But keep in mind, though, that air crescents aren't, solely indicative of fungal infections.
Right.
They can also result from, necrotic tissue or even blood clots within a cavity.
Makes sense.
Okay. Next, we have air trapping. which the glossary categorizes under both physiology and pathology. So reflecting its functional and disease-related aspects.
Okay.
This is a finding you'll primarily assess on expiratory CT scans.
Yeah.
And it essentially signifies the abnormal retention of air in the lung tissue that's located distal to some form of airway obstruction.
Okay.
So the crucial point to remember, as the glossary emphasizes, is that the term air trapping should only be applied when you observe it on an expiratory CT. The key imaging features are a less than normal increase in lung attenuation and a reduced decrease in lung volume in the affected regions on expiration.
So, like, less attenuation change than you would expect.
Right, exactly.
Yeah.
What you might find interesting is that these areas of air trapping often have, very sharply defined borders, but sometimes it can be challenging to distinguish them from areas of decreased attenuation that are caused by vascular abnormalities.
Okay.
And air trapping is also frequently associated with decreased perfusion in those same lung regions.
Makes sense.
Okay. Now let's talk about the actual gas exchanging components of the lung, the airspace, which is classified under anatomy. This term encompasses the parts of the lung parenchyma where gas exchange takes place.
Right.
So the respiratory bronchioles, the alveolar ducts, and the alveoli themselves. Importantly, it excludes the purely conducting airways such as the terminal bronchioles. You'll often see this term used in conjunction with descriptors like airspace opacity or airspace nodule, indicating that these structures are filled with some material.
Yeah, exactly. And speaking of the passages that conduct air, we've got airways, which is also under anatomy.
Right.
These are defined as the structures throughout the respiratory system that allow for the flow of air.
Right.
They're broadly divided into the conducting airways, which extend from the nares down to the terminal bronchioles, and the respiratory bronchioles, where gas exchange begins. The glossary also makes a distinction between large airways, so that's the trachea, main bronchi, lobar bronchi, and segmental bronchi, versus the small airways, which include the subsegmental bronchi and those even smaller bronchioles, less than 2 millimeters in diameter.
Right.
And this distinction is clinically relevant because diseases affecting the central large airways are often directly visible on CT, whereas diseases of the more peripheral small airways often manifest indirectly, as we discussed with air trapping.
Right. Makes sense. Okay, so now we're moving into how we describe where things are located within the lung. Which brings us to the comprehensive section on anatomic distribution, all helpfully categorized under anatomy. So this is a collection of terms that are really essential to accurately pinpoint, the spatial pattern of disease on imaging.
Right. This is crucial for clear and precise reporting. So let's go through them systematically.
Okay.
So bronchocentric refers to a distribution that's adjacent to or directly involves the bronchi within the axial interstitium.
Okay.
Then we have centrolobular, which, as the name implies, indicates that the finding is centered around the core structures of the secondary pulmonary lobule.
Right.
This is a common pattern you'll see described for nodules or micronodules.
Okay.
And then diffuse is a relatively straightforward term, meaning that the abnormality is distributed throughout a lobe or multiple lobes without any specific predilection for a central or peripheral location.
Makes sense.
And then endobronchial is also quite clear. It describes something located directly within the lumen of a bronchus.
Okay.
Extrapleural refers to a location outside of the pleural layers without directly involving the pleura itself or the pleural space.
Got it.
Fissural describes a lesion or process that originates from or involves an interlobar fissure. And the glossary makes an important distinction here between fissural and parafissural, where the latter indicates that the finding has direct contact with a fissure, but doesn't actually arise from it.
Right.
Focal is a simple but important term, indicating that the abnormality is confined to one distinct area.
Okay.
Then we have geographic, which is a descriptive term that kind of evokes the image of a map, suggesting well-defined borders between areas of differing lung attenuation.
Okay.
Multifocal simply means that the abnormality is present in 2 or more distinct areas.
Right.
Parabronchovascular describes a distribution that runs along the bronchovascular bundles, those pathways containing the airways and blood vessels within the lung. Paralobular refers to arcade-like or curvilinear opacities that appear to outline the margins of the secondary pulmonary lobules.
Got it.
Paralymphatic indicates a distribution along the lymphatic vessels of the lung.
Okay.
And then we come to the terms related to the pleura.
Yeah.
Pleural means that the abnormality originates from or directly involves the pleura.
Right.
Similar to the distinction we made with fissures, pleura-based means that the finding is in contact with the pleura but doesn't arise from it.
Okay.
And the glossary specifically addresses the term subpleural,
Yeah.
recommending that you use the term peripheral instead to describe findings that are in close proximity to the pleura but without direct contact.
Okay.
As subpleural has been used inconsistently.
Right.
And finally, the Fleischner Society strongly recommends that you avoid using the prefixes juxta, such as juxtafissural or juxtapleural, in favor of these more specific and descriptive terms we've just reviewed. This level of detail in describing anatomic distribution is really critical for accurate and unambiguous communication in your radiology reports.
Absolutely. So, shifting our focus from the lung periphery to the mediastinum, we encounter the aortopulmonary window, defined under anatomy. This is a specific compartment within the mediastinum that has very well-defined boundaries.
Okay.
The ascending aorta anteriorly, the descending aorta posteriorly, the aortic arch superiorly, the left pulmonary artery inferiorly, the trachea and left main bronchus medially, and the mediastinal pleura laterally.
So it's like this little box defined by all these structures.
Exactly.
Yeah.
And it's not just an empty space. The aortopulmonary window actually contains important structures such as lymph nodes, connective tissue, vital nerves like the left phrenic, vagus, recurrent laryngeal nerves, as well as the left bronchial arteries.
Right.
It's even further subdivided into medial and lateral portions by the ligamentum arteriosum. So this is a really key area to carefully assess.
Yeah.
At both radiographs and CT.
Right.
Because small lesions within this space can sometimes be difficult to detect, just on plain films.
Yeah, makes sense.
Okay, moving back up to the apices of the lungs, we have the apical cap, a term classified under pathology. These are those, cap-like soft tissue densities that you often see at the very top of the lungs.
Yeah.
And they're frequently bilateral. The most common underlying cause is fibrosis of the lung and or pleura, which leads to the displacement of that extrapleural fat.
Okay.
What's interesting is that the glossary mentions chronic ischemia as a potential contributing factor, leading to elastotic fibrosis of the visceral pleura.
Interesting.
So while apical caps are often associated with the aging process, they can also be caused by fluid collections, resulting from infection, neoplasm, or trauma located either in the extrapleural space or within the pleural space itself. On the left side, a hematoma, perhaps from an aortic rupture, can also present as an apical cap.
Makes sense.
Additionally, they note an association with upper lobe fibrosis, including pleuroparenchymal fibroelastosis.
Oh, okay.
So, now when the normal organized structure of the lung is disrupted, we use the term architectural distortion, another pathology term. This refers to a focal or more widespread disruption of the usual arrangement of the airways, vessels, and the interstitial tissue. You'll often see this accompanied by loss of lung volume, and it's a characteristic feature of fibrotic lung diseases.
Right.
Okay, changing gears a little bit to a specific occupational lung disease that you need to be aware of, we have asbestosis, categorized under pathology.
Yeah.
This is a form of pulmonary fibrosis that predominantly affects the lower lobes of the lungs.
Okay.
And it's caused by the inhalation of asbestos fibers, typically in an occupational setting.
Yeah.
And it's important to remember that even if the fibrosis doesn't progress significantly, individuals with asbestosis have an increased risk of developing lung cancer.
Right.
Asbestos exposure also elevates the risk of mesothelioma. Although asbestosis itself usually requires a higher level of asbestos exposure.
Okay.
While pleural plaques can often be present in individuals with asbestosis, their presence is not essential for making the diagnosis.
Interesting.
Moving on to a clinical scenario you encounter all the time, aspiration.
Yeah.
It's a pathology term.
Right.
This simply refers to the unintended inhalation of foreign material, whether it's solids or liquids, into the airways.
Right.
And the consequences of aspiration can vary depending on the nature and volume of that aspirated material, as well as its distribution within the lungs.
Right.
It can lead to atelectasis, inflammation, which the glossary terms aspiration pneumonitis or bronchiolitis,
Okay.
or even infection, known as aspiration pneumonia.
Yeah.
These complications are most commonly seen in the posterior segments of the lungs and often involve anaerobic bacteria.
Makes sense.
Over time, repeated aspirations can result in scarring and bronchiectasis.
Right, in various locations, often influenced by gravity. Yeah. Okay, now let's delve into atelectasis, another pathology term. Yeah. That describes the partial or complete collapse of a lung. Okay. The glossary outlines several underlying mechanisms, ranging from a loss of negative pressure within the pleural space to compression from external factors like pleural effusions, the reabsorption of air due to airway obstruction, or even an increase in alveolar surface tension, as a result of surfactant dysfunction.
Okay.
And when you identify atelectasis on imaging, you'll typically observe a reduction in lung volume, an increase in lung attenuation in the affected area, and often the abnormal displacement of interlobar fissures, bronchi, and pulmonary vessels.
Yeah.
Adjacent lung lobes may even undergo hyperinflation to compensate for the collapsed lung.
Right.
The glossary also notes that atelectasis can lead to the obscuration of normal cardiac and mediastinal borders.
So then they provide a helpful breakdown of the different subtypes of atelectasis.
Right.
So lobar atelectasis, as the name suggests, involves the collapse of an entire lung lobe. Linear atelectasis, previously referred to as plate-like or band-like atelectasis, describes a localized form of collapse that has a characteristic linear shape, often seen in the dependent portions of the lungs. The glossary makes an important clarification here, pointing out that while it may appear linear on cross-sectional imaging, it's not actually a one-dimensional structure.
Makes sense.
Then we have rounded atelectasis, which is a particularly interesting entity, characterized by a rounded area of collapsed lung that's associated with the infolding of fibrotic pleura and thickened interlobular septa.
Okay.
This is often a sequela of chronic or recurrent pleural effusions, such as those seen in asbestos-related disease, or chronic heart or kidney failure. On imaging, it typically presents as a rounded mass. That abuts the pleura, often with adjacent pleural thickening and the characteristic appearance of distorted vessels and bronchi converging towards the mass, which is known as the comet tail sign.
Right.
And it's most commonly found in the posterior lower lobes.
Okay.
And finally, the glossary defines segmental atelectasis and subsegmental atelectasis, referring to the collapse of an anatomical lung segment or subsegment, with subsegmental atelectasis often having a linear appearance.
Okay.
So here's a descriptive term that's, quite visually distinctive.
Yeah.
The atoll sign, categorized under pathology.
Okay.
It's also sometimes referred to as the reversed halo sign.
Oh.
This is when you see a focal area of ground glass opacity that's completely or partially surrounded by a ring of consolidation.
Okay.
And while this sign was initially described in the context of organizing pneumonia, it's important to know that it's not specific to that condition, and it can be seen in a variety of other lung diseases as well. Recognizing the atoll sign can be a valuable clue that helps you narrow down the differential diagnosis in certain cases.
Yeah.
Okay, now let's return to the mediastinum.
Okay.
For the esophageal recess, an important anatomical landmark. This is a recess in the right posterior mediastinum, where the medial portion of the right lower lobe extends.
Okay.
It's bordered superiorly by the azygos arch, posteriorly by the azygos vein and pleura, and medially by the esophagus.
Okay.
On frontal chest radiographs, you can often appreciate the medial aspect of this recess as a vertical interface, and the superior aspect as a smooth arc. And any distortion or obliteration of this normal radiographic appearance can be a subtle indicator of underlying, mediastinal or pulmonary disease.
Right.
And as we discussed earlier with the aortopulmonary window, this recess is also significant on CT imaging.
Yeah.
Because small lesions located within it can sometimes be radiographically occult on plain films.
Makes sense.
We're covering a lot of ground here.
Yeah.
Next up is bleb, a pathology term. This refers to a small, typically less than a centimeter in size, circumscribed air-containing cystic structure that's located exclusively within the visceral pleura.
Okay.
Blebs have been associated with small airways disease and are often found in individuals who smoke.
Right.
And they can be a cause of spontaneous pneumothorax. What's interesting is that blebs are often more readily identified on pathologic examination of lung tissue than they are on routine imaging studies.
Okay.
Okay, here's a more general term that you might use in your descriptions. Blood flow redistribution.
Okay.
It's a term categorized under pathology.
Right.
This is a non-specific term used to describe changes in pulmonary blood flow patterns that can be observed on both radiographs and CT scans. These changes often reflect underlying conditions, such as fluid overload or chronic heart failure.
Makes sense.
Okay. Now we return to the smaller airways, with bronchiole, an anatomical term.
Yeah.
These are the peripheral airways within the lung that don't contain cartilage. The terminal bronchioles represent the most distal portion of the conducting airways, and they subsequently give rise to the respiratory bronchioles, where gas exchange begins.
Right.
Normally, bronchioles are not visible on CT scans, but when their walls become thickened or their lumens become filled with material, they can become visible as small nodular opacities, or in the characteristic tree and bud pattern.
Okay.
And bronchiolitis is the term used to describe inflammation or infection of these small airways.
Yeah.
And when these bronchioles become abnormally and irreversibly dilated, we use the term bronchiectasis,
Right.
a pathology term. The glossary recommends using the more general term bronchial dilatation if the chronicity of the dilatation has not been established.
Okay.
Bronchiectasis can develop as a consequence of chronic inflammation, congenital abnormalities of the airways, or chronic infection or obstruction of the more central airways.
Right.
And you'll often see findings, such as bronchial wall thickening and mucoid impaction associated with bronchiectasis.
Okay.
On CT, key diagnostic features include a dilated bronchus having a larger diameter than its adjacent pulmonary artery. That's the signet ring sign.
Okay.
A lack of the normal tapering of the airways as they extend peripherally, and the visualization of bronchi within 1 centimeter of the pleural surface, giving rise to the appearance known as tram tracking.
Yeah.
The bronchial walls themselves may be thickened,
Right.
and there may be evidence of adjacent scarring in the lung parenchyma. The glossary also defines specific subtypes of bronchiectasis.
Yeah.
So traction bronchiectasis refers to bronchial dilatation that occurs in the setting of pulmonary fibrosis, where the dilated bronchi typically have thickened and irregular walls due to the traction from the surrounding fibrotic tissue.
Okay.
It's important to reserve this term for cases where fibrosis is present
Makes sense.
and traction bronchia.